Let's jump straight into the next best step decision logic for pulmonary, vascular, and pleural emergencies. For a patient rolling in with acute dyspnea and pleuritic chest pain, your absolute first question has to be, are they stable? If you see hypotension, severe hypoxemia, or shock, you're immediately pushed toward emergency treatment. You literally don't have time for a slow, step-by-step diagnostic sequence.
Let's look at this classic board-style vignette. You've got a ventilated patient who suddenly develops hypotension, tachycardia, and unilaterally absent breath sounds. What's the diagnosis? Well, sudden collapse during positive pressure ventilation combined with those absent breath sounds strongly points to a tension pneumothorax. It's a massive, immediate pleural emergency.
So how do we differentiate a primary spontaneous pneumothorax from a tension pneumothorax? It comes entirely down to hemodynamics in the physical exam. A tension pneumothorax is life-threatening. You'll see hemodynamic instability, distended neck veins, and tracheal deviation pushing away from the affected side. A simple spontaneous pneumothorax, on the other hand, maintains stability. In fact, if it's a small, primary spontaneous pneumothorax in a stable patient, you might just observe them with oxygen in follow-up.
When you look at the imaging, you're hunting for that collapsed lung edge, the visceral pleural line, and all that radiolucent air filling up the pleural space. But here's a huge test-taking trap. If the patient is highly unstable, waiting for this X-ray is a massive delay of care. In the acute setting, bedside ultrasound is your best friend. It's highly sensitive, incredibly fast, and will immediately show you that absent lung sliding. Okay, so if you suspect a tension pneumothorax, immediate needle decompression is your absolute next best step, and you follow that up with a chest tube. Whatever you do not intubate them prior to decompression. That positive pressure ventilation will rapidly worsen a collapse and induce fatal obstructive shock. Now keep in mind, a chest tube is also your go-to for hemothorax, empyema, large complicated effusions, and persistent air leaks. You'll also use one for larger symptomatic or traumatic pneumothoraces depending on the severity.
Let's shift gears to a very specific presentation. Picture a tall, thin adolescent boy with a history of asthma. He comes in with acute chest pain, dyspnea, a cough, and a literal crunching sound over his heart. That crunching sound is the Hammer's sign, and alongside subcutaneous emphysema, it's a huge red flag for spontaneous pneumomediastinum. The risk factors usually include an asthma exacerbation or a recent respiratory infection. But here's the key difference from a tension pneumothorax. The treatment here is strictly conservative. We're talking rest, analgesics, and making sure they avoid Valsalva maneuvers so they don't worsen the air leak. You can see exactly why on this chest X-ray. Look at the radiolucent gas outlining the mediastinum and pericardium. That's called pneumopericardium. But because this patient is hemodynamically stable, you don't need any invasive decompression. Pivoting to pulmonary vascular emergencies now, imagine a patient in moderate distress with a very high clinical likelihood of a pulmonary embolism. What crucial step has to happen before you even think about diagnostic imaging, assuming there are no contraindications? First, you stabilize them with oxygen and IV fluids. Then, if they're in moderate to severe distress, have a likely PE, and have no absolute bleeding contraindications, you must start anticoagulation before obtaining your diagnostic test. Seriously, do not delay a heparin drip just to get them to the CT scanner. To figure out if a PE is actually likely, we rely on the modified Wells criteria. If that total score is greater than 4, a PE is highly likely. And here's the kicker for these high-risk patients. Bypass the D-dimer completely. A negative D-dimer just isn't powerful enough to confidently rule out a PE in a high-risk scenario. Following that logic, a likely PE means you go straight for immediate CT pulmonary angiography. But if the PE is unlikely, meaning a Wells score of 4 or less, that's when you start with the D-dimer assay. If that D-dimer comes back less than 500, you've safely ruled out the PE, saving your patient from unnecessary radiation and contrast. No, while CT pulmonary angiography is definitely the gold standard to confirm a PE, it has its limits. If your patient has severe renal disease and can't tolerate IV contrast, you have to pivot to a VQ scan, a ventilation perfusion scan. The VQ scan is also the preferred alternative for pregnant patients to minimize fetal radiation exposure. What if your patient with a suspected PE is hemodynamically unstable and hypotensive? You completely bypass the CT scanner. Instead, rely on emergent bedside transthoracic echocardiography to rapidly check for new right ventricular dysfunction like dilation or hypokinesis. That finding presumes a massive PE. And just a quick reminder on PE clues. Watch for acute dyspnea, pleuritic chest pain, syncope, hemoptysis, and mild atelectasis. Also, don't get tricked looking for classic ECG signs like the Hampton hump, Western mark sign, or S1Q3T3. They're actually really rare. Simple sinus tachycardia is far, far more common.
You absolutely need to memorize the rigid difference between a massive and submassive PE. A massive PE is defined by hypotension, specifically a systolic blood pressure less than 90, plus right ventricular dysfunction. A submassive PE also has RV dysfunction or elevated biomarkers like troponin or BMP, but critically, there is no hypotension. That presence or absence of hypotension entirely dictates how you escalate treatment. Breaking that down, low-risk PEs just get standard anticoagulation. Submassive PEs need highly individualized strategies and close monitoring. But massive PEs, those demand aggressive reperfusion right away, with systemic thrombolysis or even surgical embolectomy if thrombolytics fail or the bleeding risk is just too high. Notice how inferior vena cava, or IVC, filters fit into this picture. They are never for routine use, mainly because they actually double the risk for recurrent DVTs down the road. They are strictly indicated only if anticoagulation is totally contraindicated, like if the patient is actively bleeding or if they somehow develop a new PE while already on therapeutic anticoagulation. Let's trace this back to the source. When evaluating the deep veins, which is where most pulmonary emboli start, what is your diagnostic test of choice for a patient with a moderate to high probability of a deep vein thrombosis?
It's compression ultrasonography. Now, unlike our unstable PE pathway, for a stable patient with a suspected DVT, you must confirm the diagnosis with compression ultrasound before you start anticoagulation. You want to avoid empirical treatment without confirmation unless it's a truly limb-threatening situation. If it's a low-probability case, you can start with a D-dimer first. While proximal lower extremity DVTs are definitely the most common source of PEs, don't forget about upper extremity DVTs. These typically present with arm swelling, heaviness, erythema, pain, and collateral non-varicose veins. They're heavily linked to indwelling central venous catheters, repetitive arm motions like heavy weightlifting, and underlying malignancies. For most of these confirmed DVTs, you'll go ahead and treat with standard anticoagulation. Wrapping up with this management tree, a confirmed proximal lower extremity DVT requires standard anticoagulation for at least 3 months, unless active bleeding forces you to use a retrievable IVC filter instead. Real quick, remember that related complications like PEs can cause bloody pleural effusions, and you'll use thoracentesis to evaluate most new unilateral or unexplained effusions. Apply light criteria to separate transudates, think heart failure, cirrhosis, or nephrotic syndrome, from exudates caused by pneumonia, malignancy, PE, or TB. Finally, keep in mind that recurrent PEs or primary lung disease can eventually cause pulmonary hypertension and cor pulmonale. Watch for exertional dyspnea, fatigue, syncope, a loud P2, right ventricular heave, JVD, edema, and hepatomegaly. You'll screen for that with an echo and confirm it with a right heart catheterization.